My name is Lindsay Kellum. I'm a research scientist on the SERP team, and I have the privilege of moderating with Harrison Fontaine and the speakers on this panel, promising clinical interventions to reduce cannabis use among at-risk consumers. So Harrison, just to tell you a little bit about him, he is the policy and program manager for the Substance Use Disorder Prevention and Mental Health Promotion section of the Division of Behavioral Health and Recovery. That's a mouthful. Harrison serves as the cannabis subject matter and legislative lead, and I'm happy to be moderating this panel with him. Harrison.
Fantastic. Thank you, Lindsay. All right, so next up we have an excellent panel for you. Our first topic is going to be led by Dr. Jason Kilmer and Dr. Katherine Walukevich-Dienst. I work with Jason. Fantastic to see him here today in person, the first time that I've seen many of you in person. Dr. Jason Kilmer is a professor in psychiatry and behavioral sciences here at the University of Washington. He is also an adjunct professor in psychology at the University of Washington. He serves as an investigator on several studies evaluating prevention and intervention efforts for alcohol, cannabis, and other drugs and their use by college students. Dr. Walukevich-Dienst is a licensed clinical psychologist and acting assistant professor at the UW. Her research is focused on identifying psychosocial and contextual factors associated with alcohol and cannabis misuse and co-use among young adults, including social influences, affect management motives, co-occurring mental health concerns, and high-risk substance use events and context. Please join me in welcoming them both.
Hey, look, it's us right there. Thank you very much for the nice introduction. When Katherine and I, when we had the chance to conceptualize this, we talked about actually in lieu of one of us taking 30 minutes, splitting it and doing a tag team, so we kind of count as one of the presentations. My presentation will be focusing on reducing harms associated with cannabis use by young adults. Before I get started, I just want to thank Dr. Bia Carlini for the invitation. It was mentioned earlier, but I don't know if people realize how much behind the scenes work Lexi Nims truly did. And if we can give Lexi another round of applause, because it was just a lot of work. I also feel like it's a major technological accomplishment when I can set our DVR to record the Hallmark Mysteries movie on Sunday. So I'd like to acknowledge the AV crew who've done all of this too, which is amazing. Those Hallmark Mysteries are really good. So diving right into this, we try to set this up with takeaways. What does this mean in the real world? And I have 3 to discuss. Key takeaway number 1 is that brief interventions work in reducing harms. Bill Miller and Steve Rolnick's motivational interviewing is such a key approach in informing the brief interventions we do. And decades of research shows the impact that this has on reducing use, harms, you name it. But it's all about what we call them in our conversations with young adults and how we assess for them. I had the honor of tag teaming with Dr. Christine Lee on a brief intervention that she tested, looking at using Alan Marlat's BASICS program, which is brief alcohol screening and intervention for college students, as a model, harm reduction focused, personalized feedback driven, using facilitators trained in motivational interviewing. And she wanted to see in college students that use cannabis at least once per month, at least 5 times per month, up to multiple times per day, could this brief intervention work? And her brief intervention showed that in-person personalized feedback interventions successfully reduced use, time spent high, and consequences. It was the latter, the consequence piece, that really took a lot of work to put some light on. At the time we launched this study, what we learned was that almost every consequence measure for cannabis was just an alcohol measure where they changed the word alcohol for cannabis. But it's a different substance, clearly. So in this initial study, the randomized controlled trial, we asked these young adults that were using 5 times a month or more, list up to 5 of the not so good things you've experienced from cannabis. This group of 212 college students generated over 800 items. We had coders try and distill that down, and we actually were able to publish a consequence measure where what we realized was we were capturing much more the experience of the students we were working with. It's not a matter of, in a brief intervention, of trying to make people look bad. That's not it at all. But if you were doing feedback and you said, well, with alcohol, we noticed you've mentioned the following 10 things that you didn't like. And hey, look at that, with cannabis, you didn't mention anything. Is it because there wasn't anything to mention or because we couldn't assess it properly? So when this measure was developed, we had 26 consequences on the final survey. 20 of 26 were endorsed by at least 10% of a follow-up sample of 18 to 23-year-olds who reported cannabis use in the past 30 days. I always think what's really, really interesting is the top unwanted outcome that students endorsed was having the munchies, which is something sometimes people joke about. But it was amazing to read in the open-ended comments how powerful some of people's disclosures were. People that said, I really struggle with body image, and I feel like I eat so much junk when I get high. Or, trying to watch what I eat and work out and stay in shape is important to me. I feel like that gets thrown out the door. So looking at the time what was even the most well-established cannabis consequence measure, people endorsed more than double on this measure. Again, it's not that we're trying to make people look bad. It's that we wanted to know, can we talk with students what the not-so-good things are that they're hoping to reduce? So when we look at the concept of what might prompt consideration of change, one of the things we try and get a sense of is what is the hook for any one person we're working with. We could see 5 people in a row who all have the same hook. We could see 5 people in a row with 5 different hooks. For some people, it's I want to do well in school. For others, it's I'm working 2 jobs. I'm really trying to make money and pay off bills. For others, it's their health. For others, it's family history. You name it. We'll often start with asking, what are the good things about cannabis use for you? First, they'll be delighted to tell you. And it was Paul Grossberg at the University of Wisconsin that in his research showed when you ask this question, it counts as expressing empathy. You're saying, I want to know why the degree to which this matters to you. Only after they've generated the good things, we ask, what are the not so good things about cannabis use for you? I run the mandated student groups here at the University of Washington for students that have violated our campus drug policy for cannabis in a state that's had legal cannabis for over 11 years. When I run these groups of about 5 to 8 undergrads, usually a couple of whom are pretty big fans of cannabis use, when I ask them, what are the not so good things about cannabis use for you, how long a list would you predict that I get from them? Not very long. I heard someone say nothing. A lot of people say 1, I got to meet with this guy. Just to make the point, 2 back-to-back groups, I eliminated the duplicates. There's the list. Surprising, because people hear, no, that people don't see any harms. People just want to be left alone to do what they want to do. I get surprised when people say, well, you can't talk to young adults about cannabis use because they don't see any problems. That's not true. It's what we call them. If I start those workshops and I say, I know you all got in trouble, sorry about that, we'll try and keep this as quick as we can. What problems have you had with cannabis? How many problems? You got a problem. What are the good things? What are the not so good things? Scott Walters at University of North Texas Health Sciences pointed out that in one of their projects, it was their clinicians prematurely ending this list. The clients they were talking to would generate these not so good things, and the provider would go, great, anything else? Anything else is a closed-ended yes-no question. And when packaged with a hand clap, it communicates, let's wrap this up. Instead, what else? What else would you add? It keeps the list going. If you ask, what would it be like if some of those not so good things happen less often, any positive or affirmative answer is what Miller and Rolnick call change talk. It's what would be in it for someone if they were to make a change. What would make some of those not so good things happen less often? Anything the person identifies is a person-identified strategy for reducing harm. So key takeaway number 2 is there may be harms and risks associated with cannabis use. It's possible, though, that young adults don't immediately see them as connected. One of the things that I'll bring up Christine Lee's name again, that I've always been impressed that she got the ball rolling on and subsequent researchers have replicated, is looking at how many motives for cannabis use by young adults could actually be signs that something else is going on. She asked incoming first-year students to the University of Washington, tell us why you use cannabis. And they said lots of things. They said, I like getting high, I like the feeling, gives me something to do with my friends, helps when I'm bored, makes things more fun, music sounds better, it's cool, it helps me celebrate. But they also said it helps me relax, helps me sleep, lets me cope when I'm depressed, helps them relieve stress, helps when my appetite stinks, reduces anxiety, alleviates physical pain, helps when I have a headache. Is cannabis addictive? Yes, there are clear criteria for cannabis use disorder. And there are even criteria for withdrawal. What does the criteria for withdrawal include? Keeping this list in mind, it's literally the same list. Anxiety, sleep difficulty, decreased appetite, depressed mood, and headaches. So if someone says, well, I use because it reduces my anxiety, how do you know it helps? Well, because every time I don't use, I get anxious. That could be withdrawal. And so particularly as people are mindful of the concept of addiction, as they're mindful of things like cannabis use disorder, do they know what to look out for? When people talk about tolerance, do they realize that's one of the criteria for a cannabis use disorder or substance use disorder in general? If they notice that these things they don't like stop happening when they resume use, could it be an issue of managing withdrawal more than treating an underlying issue? Finally, for me, if we agree cannabis use disorder and/or cannabis withdrawal are potential risks or harms, we have to consider factors that could be associated with the onset of cannabis use disorder. We started looking at endorsement of symptoms of cannabis use disorder in our young adult health survey. Our team is delighted to partner with the Division of Behavioral Health and Recovery, Sarah Mariani, Sandy Salavares, on what is now in its 11th year, a survey of 18 to 25-year-olds. We had an article published in 2022, just shy of 13,000 young adults in Washington, looking at 6 time points. Data that were collected largely before the first retail stores opened in Washington in 2014, and the 5 time points later. We covaried quite a bit. Sex assigned at birth, race, ethnicity, geographic region of the state, age, 4-year college status or not, and full-time employment status. And then additionally applied post-stratification weights to make the sample more similar to the general population. What we saw is that after implementation of 502, after stores opened, we saw a significant increase in any past year cannabis use in this age group of 18 to 25-year-olds, a significant increase in at least monthly use, at least weekly use, and at least daily use. When we did a deeper dive, for some of these variables, it was the 21 to 25-year-olds really driving that increase. We can see with any past year use, that's the case, and at least monthly cannabis use. With a shout out to Isaac Rue, who was just amazing in helping us really understand the clinical significance of this. Isaac helped us look at endorsing at least 2 past year cannabis use disorder symptoms. We would never diagnose a substance use disorder from a survey. It's more complicated than that. But if people endorse these items, it could mean that something's potentially going on. We have seen a statistically significant increase in endorsing at least 2 past year cannabis use disorder symptoms. So first, we want to consider that in the context of implementation of legalization. It was ADAI themselves that in the high potency work group invited researchers from the University of Washington and Washington State University to generate a consensus statement on high potency cannabis. And among the conclusions were the high potency products are something to take very seriously, especially before the age of 25. The group concluded that young people, adolescents, college students, young adults may be experiencing more unwanted outcomes when they use high potency cannabis or use more frequently. And that was particularly true in the second point of the risk of developing cannabis use disorder or addiction, particularly when products are high. I will end with 2 slides from me. This is data that came out just in our report we sent out this spring to the state. And this is daily non-medical use of cannabis by age group. Daily use in general is the highest that it's been since we've been collecting data. But you'll notice that in 2014, 21 to 25-year-olds and 18, 19, 20-year-olds were almost identical on their daily use. You can see how that's really branched apart, such that at this point we're almost at 14%, but over 10% of the over 18 to 25-year-old age group using daily. Think of everything we heard about in the morning, but also think about the recommendations from that work group from ADAI. The more often people use, the more we start to see increased risk for a range of unwanted outcomes and harms, as well as risk of substance use disorder. And finally, we ask, among those with past 30-day cannabis use, what's the typical potency you're getting in your preferred method of use? Noteworthy is that about 41% of 18, 19, and 20-year-olds say, I don't know what the potency is of what I'm using. The 21 to 25-year-olds, it's a little over a third as well. But you can see that of the 18, 19, and 20-year-olds, of those that do know, essentially half say their preferred amount is 71% or higher. With the 21 to 25-year-olds, you can see almost a bimodal distribution. There's 19.35% that say they prefer 21 to 30, but it's another 20% adding that 6.43 and the 1402, similarly endorsing the 71% or higher. So we do know brief interventions can be part of an overall prevention approach. And assessing and describing harms the young adults see as not so good could be what prompts consideration of change or even commitment to change. Decades of research, probably starting in 1982 with David Hansen, shows that if we give people facts and knowledge, they learn stuff, but it doesn't change their behavior. So information-only approaches don't tend to change behavior, but information has its place in a motivational framework. And as we monitor daily use and use of products with higher potency, we can consider what to offer those experiencing cannabis use disorder or withdrawal. With that, I will thank you for the chance to present, and I will tag team over to my friend and colleague, Katherine. Katherine, come on up.
Hi, everyone. This is my first in-person talk since COVID. So I'm used to being behind a screen, so this kind of helps. But thank you, Jason, for setting me up for what I'll be talking about. And so Jason talked a lot about the hooks. So what are the things or what are the reasons why people might consider changing or want to change their cannabis use? But what I'll be talking about for the next several minutes are when we might do this. So not just how we might promote change, but at what point in time might we be most or more effective. So I'll be talking about kind of novel catalysts or points of intervention for promoting or encouraging cannabis-related change. I'll be talking about holidays, high-risk use events, and temporary abstinence as well. AKA, these are things that I'm excited about, and I think that we should be researching more. When we look at our first key takeaway here, when I was in graduate school, I was really interested in this idea of high-risk use events. So points in time where people might be at higher risk for experiencing consequences related to their use. And I was actually pretty surprised that there was very little published research, one other study at the time, on April 20th or 420. And I'm curious, just by a show of hands, how many people have heard of 420 as a cannabis-related holiday? All right, I figured I was in the right place to ask that question. But what this initial research showed, it's very preliminary and kind of a small sample. It was my first graduate school project. But what I found was that 420 is an especially high-risk day for heavy use, but also consequences as well. And so with this day, we know when it occurs on the calendar. We can plan ahead. We can plan afterwards. Both prevention and intervention might be super helpful and useful around this time. So like I mentioned, 420 tends to be this cannabis-specific event in the US and internationally as well. And it's somewhat of an unofficial holiday to celebrate cannabis and cannabis culture. When I was writing the paper, I tried to find a lot about the history, and there's kind of a lot of different mysteries surrounding where this came up from, which I won't get into here. But regardless, we've heard of this, right? And we know that folks tend to use on this day. But I was really surprised at the lack of research that actually showed this. And so I was in Louisiana at the time, which cannabis is and was illegal recreationally, and so I do think that's a difference that might occur between here and Louisiana. But I recruited college students, about 120 of them, the week after 420. And what we found was, yes, college students who used cannabis in the past year tend to use cannabis on 420. But I think it's important that even though more than half did, a substantial portion didn't. So not everybody is using cannabis on 420, but about 57% of folks did. Even though a majority of the sample that I recruited were infrequent users in general. So even though they were using several times a month or less on average, they chose to use on 420, which I think is interesting. In addition, this was a social event. They weren't just using home alone. A lot of folks attended at least one 420 event, including smokeouts, which were specific to using cannabis, where cannabis was available for that time. not only were they using, I was like, okay, well, how much? Does it matter whether or not? Who cares if they're using on 420? So I asked, how much did you use on 420? An estimated number of joints, which is an imperfect metric, as we all know, and compared that to other high-risk events in the past month. And so as you can see here, kind of on the left, people used, on average, significantly more joints on 420 than any of the other high-risk use days that we assessed, including their maximum past 30-day use, spring break, and St. Patrick's Day as well. In addition, not only were they using a lot, they were becoming pretty intoxicated. So about 55% of the sample said they got high or very high on 420, and about 21% said they were stoned. And so they're using a lot, and when folks do choose to use on 420, they were using a lot of it and becoming quite intoxicated. So when I tried to publish this is my first author paper. I submitted it to, I think, 8 journals, and I had a really hard time getting people excited about this. And I will never forget a reviewer who said, who cares? Of course people use on 420, which we don't see that in the data, and we don't see that. So who cares? This is just a holiday, they're having fun. And so I think the so what question is really important here. You know, I want people to have fun too. But what we see is that consequences are really high on this day. So about 72% of folks reported at least one negative consequence on 420. And on average, about 6 individual consequences on that single day related to their 420 use. I think this is super important. I was really surprised because we also assessed the average number of consequences over the past 3 months. Over the past 3 months, they reported 4. So on this single day, they reported almost 6. Over the past 3 months, they reported 4. So that's a lot of consequences on a singular day. In addition, again, this was in Louisiana, but almost 6% of folks, students, got in trouble either kind of with campus or with the police on 420. I also looked at whether they consumed other substances, and specifically alcohol, and about 1/3 of students also drank on 420. And I think I want to highlight here kind of this number. So they weren't just having 1 or 2 drinks. On average, students were having about 5 drinks across 3 hours. So they're getting super stoned, and they're also drinking at a rate that could be considered, heavy episodic or binge drinking. So how might this apply to prevention? So as Jason was talking about, prevention efforts are relatively easy to disseminate and somewhat effective. And we know that this can help reduce cannabis use and related harms. But we also know when 420 occurs on the calendar, so we can plan for it. Some of the research in alcohol particularly seeks to change norms, to correct norms about how much we think other people are using compared to what the data actually says. And we can see here that particularly for spring break in 420, norms were much higher of how much other students thought people used versus what the actual use was, even though the actual use was quite high. But for cannabis specifically, changing norms seems to be a little bit more challenging, in particular because some people want to use a lot on this day. So they're like, okay, well, whatever, most students use less than me, I don't care, I'm planning on using this much anyway. So we might kind of want to take a different direction than we use for alcohol than we use for cannabis, particularly for this high-risk event. Because folks are experiencing so many problems and different types of problems, I think potentially focusing on problems. So you want to use it on 420. What do you want to happen? What are the good things you want to happen? And what are the not so good things you want to avoid? And then checking in afterwards, having them, before coming up with a plan. How can you avoid legal trouble if that's something you don't want? How can you avoid feeling too stoned if that's something that you don't want? And having them come up with a plan, sending it out the morning of, hey, happy 420, just a reminder, this was your goal for today, this is what you're hoping to avoid, and here are your ideas at how you can meet that goal. So again, it's not taking away the fun for people who do want to use, but how do you use in a way that is more fun than not fun and helps you avoid some of those not so good things. I think also, in general, for folks who might not use on 420, normalizing that as well. So not everybody uses on 420, unlike that reviewer that I'm still bitter about this many years later. But that, future work could be to have some sort of prevention effort around this high-risk time. And then if we think about intervention, I didn't unfortunately measure readiness to change, but in theory, motivation might be higher after somebody experiences a bunch of problems or consequences related to their use. And so if we think about when we might deliver an intervention, 420, post-420 might be a good time. Folks might be like, I'm not really enjoying kind of this effect, or I didn't really like how much I used and what happened here. So if we are kind of not specifically focusing on 420, our intervention efforts might be prudent, particularly after that time. In grad school, I also kind of ran a study where I developed a consequence-focused intervention, and we found that folks who were more distressed by their problems had better outcomes in reducing their use and consequences. Reducing their consequences when they received that problem-focused intervention, which makes sense. I'm more distressed by it. I'm getting content that is consistent with my values and what I'm hoping to do with my change, to have them experience less consequences. All right. So key takeaway number 2 is a little bit different. So 420 is a particular day on a calendar we might want to intervene at. But there might be other times where motivation is high, then that's different or unique from wanting to quit or wanting to reduce their use. So like was mentioned earlier, I'm also a licensed clinical psychologist. And so when I work with young adults who use cannabis, I kept hearing this idea of a tea break. And I was like, that sounds nice. Like, I like green tea. And they're like, no, like it's actually called a tolerance break for cannabis. And it's folks who are trying to remain abstinent from cannabis temporarily in order to reset their tolerance or for some other reason. I'm curious, show of hands again, how many people have heard of this concept of a tea break or tolerance break? So still, a good number of people here. And so often when Jason and other colleagues and I put in grants about interventions or prevention efforts, thank you, we see that we get this feedback, people aren't interested in changing. But temporary change is still interest in change. It might be a really important point to intervene on, that point of entry. I'm not interested in permanently quitting, but I'm not totally happy with where things are right now. So I just got my 2-minute warning, so I will speed up a little bit. But what we sought out to do was really understand, again, I was shocked. There was only 2 published studies on tolerance breaks. And what we found, kind of looking at and asking folks about it, is that this behavior comes up pretty commonly. If you Google it on cannabis.com, people are recommending taking tolerance breaks. But we actually don't have a ton of good guidelines around how long or what that might look like. But I asked young adults who use cannabis daily or near daily, have you taken a tolerance break and what did that look like for you? And so what we found is that young adults are defining tea breaks as an intentional but temporary period of abstinence. They're often short and unplanned, so often only several days or so and not necessarily planned in advance. And there's a lot of different motivations above and beyond tolerance why people might take this change. So including reducing tolerance, but also they want to save money, they're having problems in their relationship due to cannabis, or they find that cannabis is impacting school or work. But we also see this theme, and I want to shout out to Ella DeVry, who was one of my RAs who's here today, who helped me code this. We found that people really wanted to reevaluate or reconsider their relationship with cannabis. And this term came up a lot. I want a good relationship with cannabis, and I'm not liking some of these things that are happening. What we also found is that it was relatively common. So we had a sample of 66 people, and we asked how often have you taken a tea break, if at all, in the past year. The majority had, and multiple times. So unlike 420, that's maybe once a year where we might be intervening, we could intervene multiple times a year when people are interested in taking these periods of time. And I just really want to highlight the work of my colleague, Tom Fantana, at University of Vermont, who developed this brief 21-day tea break guide that has just like blown up in popularity. I'm not sure if people have seen this. It's disseminated by over 100 colleges and has become very popular online. But it's really in its infancy. It was a pilot study, pretty small. But people loved it, young adults used it, and the people who used it a lot had much better outcomes, including more willingness to take a break later on. So again, they're not necessarily quitting, they're not necessarily stopping use, but this might be a really viable harm reduction option for folks who want to change their use but don't want to stop. There is some evidence in the literature, like dry January for alcohol, practice quit attempts for nicotine and tobacco, that have shown success in this realm. So just to kind of sum it up, it's not just important how we intervene, but when. And these are two potential options that I see as great future directions that we all need to be studying, in my personal opinion. Thank you so much for having me. And I put my contact information up here if you have questions. Thank you.
Thank you. All right, our next speaker I'm very excited to introduce is Dr. Denise Walker. Dr. Walker and I have worked very closely on this next topic, so I'm excited for her to share that with you. Dr. Walker is a research professor here at the University of Washington. She's also the director of the Innovative Programs Research Group and is a licensed clinical psychologist. A main area for her research expertise is on the development and evaluation of interventions for cannabis use disorders for both adults and adolescents, utilizing brief interventions, longer courses of treatment, and aftercare. So Dr. Walker, please help me welcome her.
Hello, thank you for having me. So we heard, earlier this morning about a lot of researchers who were really primarily psychosis researchers, people who worked in the area of psychosis and schizophrenia. Okay, is that better? Okay. And I have really, for most of my career, really been more of a cannabis treatment researcher and substance use treatment researcher. Today I'm going to be talking about a collaboration and a product that happened with Dr. Bia Carlini through legislative funding, an intervention that we have developed called CannTalk. But first I'd like to acknowledge some of my investigators that have been in this work focusing on the intersection between cannabis and psychosis, specifically how do we intervene with this population. So these are a few of my fabulous collaborators. We've been doing this work for about 5 years now. So to tell you where I'm going to go in this little chat we're having, I'm going to briefly review cannabis treatment literature for the general population. What does that have to tell us about how to intervene with psychosis? And also talk a little bit about, we've done 2 small studies, formative research on trying to figure out what is needed for young adults with psychosis as far as cannabis intervention. I'm going to describe the whole CannTalk intervention and suite of resources, and then briefly talk about next steps. So I don't know if you felt a little bit like this after this morning of hearing how devastating cannabis's effects can have on folks with psychosis, or even as a prelay into developing psychosis. I feel like this a lot. So clearly there's an urgent need for interventions to work with this population of folks experiencing psychosis to intervene with their cannabis. And at this point, we really don't have an evidence-based intervention to do so, not that has been informed by the literature. When we've surveyed Washington state providers who work with folks who are primarily working with populations with psychosis, they're saying, you know what, I don't feel like I have the skills to address this in clinical sessions, and they're wanting more evidence-based interventions and more research-based educational materials to work with their clients. So what does the cannabis treatment literature have to say, or what can we learn from that 30-year literature of studies evaluating different interventions and treatments for cannabis use disorder? Well, I think it's important to note that, again, we have this nice history of treatment studies. So a number of studies also have focused specifically on non-treatment seekers, which is important because the far majority of folks who are experiencing consequences related to their cannabis use disorder or actually have cannabis use disorder are not seeking treatment. Motivational enhancement therapy is the intervention that's been studied the most. So, yay! We have effective treatments. The literature clearly demonstrates that. Motivational enhancement therapy, which is a combination of motivational interviewing and personalized feedback, is one of those interventions. Cognitive behavior therapy, contingency management, which is a whole behavioral protocol where we pay people essentially to maintain abstinence from cannabis. The gold standard in literature is considered a combination of those three: MET, CBT, and contingency management. And for adolescents, the good news is all those interventions work pretty well for them as well. What you do see the addition of are family treatments. So things like multisystemic therapy has also been identified as a really effective treatment for adolescent cannabis use disorder. So the thing about motivational enhancement therapy is, again, it's the most studied intervention, and it's been looked at in like the range of cannabis use disorder kind of ways to intervene. So we've absolutely used it in pre-treatment, opportunistic settings, but also checkup models where we're trying to attract voluntary participation from adults or adolescents to think about their cannabis use and talk with us about it. We've used it as a treatment in and of itself, or as a combination treatment. And I've actually developed a maintenance checkup for folks who have done treatment for cannabis use disorder, and then we use a MET intervention to help maintain those gains and continue motivation. Motivational enhancement therapy has been shown to be effective for reducing cannabis use in adolescents, adults, college students, as Jason talked about, and it hasn't been tested in young adults with psychosis. Motivational interviewing has been tested in psychosis populations, but motivational interviewing is one part of motivational enhancement therapy. And we think that that feedback piece, the personalized feedback, may be particularly potent for psychosis populations. Also, in the literature for the psychosis and cannabis interventions, oftentimes the outcomes are abstinence-based, and we don't have a lot of good luck in the treatment literature evaluating and finding successful interventions when we look at only abstinence. We can talk about that later. It could be a whole talk. Okay, so, like I said, about 5 years ago, I got together with colleagues who were really expert in psychosis and early psychosis, and we're trying to figure out, how can we optimize some of the interventions in cannabis treatment literature for this population? What do they need? What do young adults with psychosis need? What do the families need, and what do the providers want? So in this particular study, we were just really interested in informing the development and optimization of, at this point, we were thinking of a combined cannabis intervention. One part would actually work and address the concerns of family members and maybe capitalize on their relationship with the young adult, give them skills to try to move their motivation towards change. The other part would be an individual intervention for the young adult itself. So we asked what facilitated and also what got in the way of having conversations about cannabis with this population. We did a number of focus groups, 8, some with just young adults with psychosis, some with providers of young adults with psychosis, and others with family members of young adults with psychosis. And basically, this is what we learned. Everybody said across those stakeholder groups that they wanted more science-based psychoeducation on the risks of cannabis use to psychosis maintenance, relapse, and rehospitalization. So these folks don't feel clear about what we heard is in the science already and what the risks are. And that's alarming to them. They want more good objective information. The other feedback that we got about an intervention is that the counseling style should be non-judgmental, non-confrontational, and likely individualized for the person. And harm reduction strategies were really desired, especially from the young adults with psychosis. Not as much from the parents, but definitely the young adults. And some providers even recognize that, if someone's not ready to quit, how do we talk about harm reduction, and is it even effective? But that was another thing that they wanted. So that was a study that was funded by the Royalty Research Fund here at UW. Then we got additional money by the Garvey Institute for Brain Health Solutions to optimize a motivational enhancement therapy intervention for these young adults with psychosis and test it, and then see, what is the acceptability and feasibility of this new intervention? Would young adults like this? Would they be okay with it? What's the story here? So the basic methodology is we had a stakeholder advisory board that was giving us feedback about the optimizations, including people with lived experience. We adapted the intervention, and then we did a small pilot study, single arm, just to see, again, about acceptability and feasibility. So we adapted motivational enhancement therapy, actually an intervention that is considered or an evidence-based practice that came out of our lab called the Teen Marijuana Checkup. And again, that combines motivational interviewing practices, which I'll describe in a second, with personalized feedback. This is an evidence-based intervention, so it's a great place to start, but it also lends well to adaptation, specifically for people who are vulnerable to cannabis risks. And so we made a number of adaptations to this intervention that were specific to psychosis, including, having prompts to talk about cannabis and treatment participation, like how cannabis may or may not affect that, feedback on how cannabis impacts rates of rehospitalization and risk for rehospitalization. We also included cannabis and symptoms of psychosis within consequence list, and we asked them specifically to talk about their experiences between cannabis and psychosis. And then we also developed a whole harm reduction tips page. So we recruited about 12, our goal was 10 young adults with psychosis. We recruited these folks nationally and delivered an intervention via telehealth. We screened them and baselined them. I had the privilege of delivering the intervention sessions, and then we followed it up with an in-depth qualitative interview to learn what they liked and what they didn't like about the intervention. About the age of the participants were about 22, mostly male. So this kind of looks like what we saw earlier this morning as far as statistics for young adults with psychosis. They were using pretty regularly on 18 of the past 30 days. And what we found from this small study is that 100% completed session 1 and 92% completed session 2, so it's a 2-session intervention. So right there it showed a lot of acceptability for the intervention. The average rating on patient satisfaction questions was a little over 4, so moderately helpful. And the checkup overall was rated even more highly. But what was interesting, 100% said they would recommend the checkup to other young adults with psychosis, and 100% say they would retain the psychosis adaptations or optimizations that we made for the intervention. This is a quote. Basically, you can see this participant said, I didn't see any cons with my marijuana use, and I didn't see anything negative about it in the beginning of the study. And then towards at the end, we started talking more like we're viewing the actual statistics and data, that it kind of shifted, and I wanted to make a change. And I have been making a change. It's actually really beneficial for me so far. Other quotes, really indicative of what they liked. They liked the goals section of the personalized feedback report, and they also liked the statistics. They liked the norms data, and they also liked the rehospitalization, even though sometimes it was very jarring to them. So great, right? We have, in 5 years, we have optimizations of an intervention and a very small pilot study. The world of science is slow, and we need interventions now. Our providers are asking for them, and they're also saying, you know what, we're overworked. We are not feeling super equipped to address this issue, so we need to kind of develop an intervention that can be used off the shelf and easily, that's brief, for providers who are working with young adults with psychosis. And we need to develop something that can kind of be accelerated into the workforce now, not wait for 5 to 6 to 7 years after a clinical trial's been done. So this is CannTalk, and we basically were awarded some legislative funding to develop this intervention based on the evidence that we had so far and a complementary training program. The goals of CannTalk, ultimately, we want to decrease the harms related to cannabis for people with psychosis. We want to decrease psychosis and psychosis-related harms. But we did that by developing an evidence-informed intervention. We developed a training program and that included a number of things. And then we were interested in evaluating how the training program and the intervention was perceived by providers using it. So this is just a fancy way that to say that we use this. We were very thoughtful in our design of the project. We used public health logic model in trying to figure out what our inputs, activities, and outputs were. We don't have long-term outcomes, but we do have some short-term outcomes, again, around providers that are sort of still in progress. All right, so what is CannTalk? We really wanted this, or I really wanted this to be something that even if you don't have a client every single day that's using cannabis that you need to have this conversation with, that you could pull it off the shelf when you needed it, and you would really need not very much else to complete this conversation and prompt a really great discussion about their cannabis use. So brief, easy to use were high priorities. Again, really considering the workforce this was intended for. It is really kind of intended to be delivered using motivational interviewing skills throughout the conversation. And it's in worksheet format, but it's not intended to be a worksheet. It's intended to be a great interactive conversation. And given that a lot of these providers have very long-term relationships with their clients, it's really thought to be a starting point in discussing cannabis, and that can be just sort of like a prompt for the long term. So CannTalk has a number of components that we developed and designed: an online self-paced training program, an online training that I conducted, and a discussion guide, the actual tool that we use with clients, and then of course an intervention manual. The self-paced online training included a number of different modules like Cannabis 101, Cannabis and Psychosis. Again, thinking about the provider and their time and resources. It was something that they could do on their own. It took about an hour, and it was interactive, quizzes, videos, things like that. But it got all that basic psychoeducation about cannabis and potency and cannabis and psychosis out of the way. We developed print materials, including the actual worksheet or discussion guide, the tool that is used in session, and then a complementary manual so that if a provider got stuck or needed some questions or wanted more information about a particular section, they have that reference manual. And then we offered 2 different dates for a 4-hour online training live. That reviewed cannabis assessment, reviewed the CannTalk, and then gave opportunities to practice using the intervention. It also did a brief review of motivational interviewing. So who is it ideal for? This really was intended to be used for young adults with psychosis or anybody experiencing psychosis but using cannabis rather regularly, so 2 or more times a week. But I think it has potential to benefit clients who are experiencing psychosis who are using less regularly. And you can adapt it in a way that may really enhance their motivation to continue using lightly or not at all. And I think also for people who are experiencing cannabis-induced psychosis, so more of that acute phase of psychosis, it potentially could be a great prevention intervention for. Again, this intervention can't be really delivered well without the use of motivational interviewing strategies to engage in that conversation. Essentially, motivational interviewing is all about being person-centered, really interested in what the person has to say, and really trying to draw out the client's own reasons for change, rather than inputting our own onto them. It includes a way of being or a way of approaching our clients that is really collaborative, accepting of the person, not necessarily the behavior, compassionate, really putting their values and priorities ahead of our own, and also empowering. So really tending to their strengths and helping them to engage with those strengths that they have. And the key skills include open-ended questions, reflective listening, affirmations. Summaries are just a special type of reflection. The basic format is really simple. It's essentially, there's you'll see it in a second, but there's a worksheet, and every topic has a question, an open-ended question designed to, elicit really change talk from the client. You're supposed to listen, ask the question, listen to their response, really get an understanding of what they're saying, maybe use open-ended questions to really expand on it, and then summarize in the worksheet what they said. The topics that are covered include, cannabis use, their personal goals and how cannabis relates to their ability to attain those goals, the relationship between cannabis and psychosis, motivation for change, so we talk about it, we have it right front and center on the table, and then next steps, what do they want to do with the conversation, with the information. So this is an example of the first page. You can see it's in that worksheet format, but it's designed, a provider can take it off the shelf, ask the question, use motivational interviewing skills to listen to the person's story and really try to draw out any types of motivations or reasons for change. Here, we ask, tell me about your cannabis use. What's it like? We get to know about it. Then we ask, what do you like about cannabis? We hear that perspective, and then also, what's not been so good about it? So that's just an example of one of the pages. This is one of the pieces of the psychosis section, asking, what have you noticed about how cannabis affects your psychosis? And so again, using a lot of motivational interviewing skills to really draw out that conversation and their experiences with cannabis and psychosis. So we developed all that stuff, and then we wanted to see, do providers like it? What do they think? And would it move the needle on some targets that we had for providers? So we sent out an email blast to a few listservs in Washington State. We were interested in getting 20 providers signed up. Within a week, we had 30. And you can see the stars represent where the providers were coming from. So we got pretty much all along the I-5 corridor and even Eastern Washington. So the target was, again, 20 clinicians to get training on the intervention and use it and give us some feedback on it. 30 actually registered within the week, and we shut the recruitment down. So there were different levels of training, right? That first piece was just the asynchronous training that they could do on their own, and we had 22 clinicians who completed the pre and post training and that asynchronous online training about facts and myths about cannabis and the relationship between cannabis and psychosis. We only had 2 opportunities, and it was the summer. It was just last summer. We had 2 dates that people could sign up for. 14 clinicians attended that live 4-hour training. So that's about 64% of the clinicians who completed the pre and post training. We completed a 1-month post training, and 12 clinicians completed that 1-month post training, and 3 months we're still in process getting the data for that. So one of our targets was clinicians to feel more knowledgeable about cannabis and psychosis and the related harms. And what we found from that was largely from the asynchronous training, It was a measure that had a cap of 16, so that was the highest score you could get. So the mean was 12 pre-training, and it went up to 15 post-training. We haven't done any fancy statistical analyses on this data yet, but you can see from the means we're optimistic. Clinicians, another target was for clinicians to feel more confident in discussing cannabis risks with their clients. And you can see we asked about their confidence. This was pre-training scores. Some people are feeling pretty super confident. And post-training, we get more in that feeling pretty confident and above. And then we were also interested in people using it with their clients. Like, hopefully they'll use the tool, right? So we did a 1-month follow-up, and 100% of the folks who attended all the parts of the training, so that asynchronous plus the synchronous live training, 100% of them intended to use CannTalk with their clients. And 75% at the 1-month follow-up had already used it. 9 out of 12 provided psychoeducation using the tool. 58% used it to discuss cannabis with their clients. We've gotten a lot of great feedback, both on the asynchronous and the synchronous training that we can employ. People tended to like both of them, but we got some also good feedback around things that we can change. They wanted more variety in the synchronous training. Some people wanted less, shorter trainings. Some people wanted longer trainings. They wanted more information on psychosis and what that would look like for families. And we got some ideas about they thought this intervention shouldn't be restricted to just providers. It should be actually opened up to maybe even peer support specialists, which is very common in coordinated specialty care, which is sort of the gold standard for young adults receiving care in the community. All right. Where am I with time? Because I feel like, how many? Wow. 2 minutes for implications. So all that to say, we need interventions. We need them now. We need them for this population. Providers are asking for it. Families are asking for it. And, from our preliminary data with the CannTalk, but also with our other data from other studies, young adults with psychosis are actually liking to have these conversations. CannTalk is an evidence-informed intervention. We looked at the literature for the general population for cannabis treatment. We looked at what we could garner from the studies that we've been working with young adults with psychosis, and this is the culmination of that. So we're trying to hopefully use legislative funds to accelerate the pathway to having a good, strong intervention to be provided to our young adults or adults in Washington state who are struggling with cannabis. So we've got some great preliminary data on the acceptability of this intervention for providers, but we really need to also evaluate this long term and see what, if any, hopefully it will have some impact on the young adults themselves, both on their cannabis use and then consequently on their psychosis symptoms. And we could also expand the products that we have developed. So a lot of people have asked about maybe using the asynchronous training, even letting family members watch that. They want to know that, sharing it with patients themselves, or even other populations that maybe even aren't psychosis related, but deal with a lot of cannabis use. All right. This is acknowledging the team and the funding that Washington State provided to develop the CannTalk materials, the intervention, and all of the training materials. And of course, my team, Bea and Lindsay, who are here, and Sharon, Lexi. So anyway, that's it.
She's tall. I'm gonna lower this. Thank you, Dr. Walker, for sharing about your work, or our work, I should say. All right, before we bring up the last speaker of this panel, we want to share a lived experience. This is Lauren. Lauren has a YouTube channel to share her experiences with schizoaffective disorder. And in this video, she discusses how cannabis impacts her schizophrenia symptoms.
So my experiences with marijuana use have been a little bit mixed, but have been kind of trending towards not so great. And so I kind of wanted to share some of my experiences with how I've slipped into psychosis with the use of marijuana in order to kind of better educate people on what the potential effects of smoking marijuana with a susceptibility to schizophrenia, or if you already have schizophrenia, what the risk factors can be or what can potentially happen if you do that. I want to share my experience to hopefully encourage others to maybe not dabble with it or to just be really cautious if they do. So when I first started trying marijuana about a year ago or so, it felt good mostly. And I understand why people with mental health issues particularly gravitate toward using substances like marijuana, because it can really help to alleviate some of the stress and burden that you feel from some of your symptoms. And it can really help to kind of numb or to just kind of soften, I guess, the symptoms that you're experiencing. And it can be really helpful in that regard. And so I understand why people with schizophrenia gravitate towards using substances like marijuana. That said, it did also increase some of my symptoms as well. So the first time that I tried it, I became really, really paranoid. I became really paranoid that people were following me. I became really paranoid that Rob was cheating on me. Like, I was convinced that he was cheating on me, and I was just so sad and distraught about this, and just ruminating on these things really, like, a lot, and really getting stuck in my paranoia. This wasn't an awful experience. It wasn't great because I was stuck in this rumination around my paranoia, but it wasn't awful. The more frequently I used it, though, which never was that frequently. Like, I've only used it like a handful of times in the last year or so. But the more frequently I used it, the more I felt stronger symptoms creeping up, and the more I felt that I was slipping into psychosis when I used. So the last time that I used, which will probably be the last time that I used in a very long time because it was a really awful experience, I slipped fully into psychosis, and I forgot who I was. I became really fixated on what schizophrenia was. I couldn't remember what schizophrenia was, and I couldn't remember that I had it, and I couldn't remember what that meant, and I couldn't remember a lot of things. And just the way I was perceiving reality was really, really altered. I also became convinced that I was living in some kind of simulation, or that things weren't really real, and that there was cameras throughout my house that were recording me in the simulation. And this whole big narrative just developed in my mind that I couldn't really get a good grip on, and I didn't really understand what was fully happening. And just my concept of reality was really, really warped. I was kind of looking to Rob to be like, are you experiencing this too? Like, what is happening? But it didn't seem like he was experiencing this either. And from what I understand, most people who smoke marijuana or substances like this don't have this kind of experience. So I think because I do live with schizophrenia or schizoaffective disorder, I was much more prone to slipping into psychosis with the use of marijuana. So I just want to really drive home that this was a really terrifying experience, and it was very much what psychosis feels like. The only difference being that this was a drug-induced psychosis as compared to a more natural schizophrenia-induced, non-drug-induced psychosis. And so it really felt like when I'm at my worst in terms of my psychotic symptoms. And that was really scary and really disorienting. And I didn't really know how best to handle that or how to really get out of that. So I just kind of had to wait for the effects of the drugs to wear off. But that said, even after the effects of the drugs wore off, I still wasn't fully able to get back out of the psychotic state that I was in. So for days later, I still felt that I was living in a simulation. I still felt that I didn't really have a good grasp on reality, and I didn't really understand what was real and what was not. And so that was a really big problem for a few days after I smoked marijuana. I think the prolonged effects also were on my mood. So I definitely had decreased mood, and I was more lethargic and didn't have a lot of energy and that kind of thing. So it really took a toll on me for the days after as well.
Alrighty, to wrap up our panel, we will have next Dr. Erin Bonar, who is a licensed clinical psychologist and a professor with tenure at the Department of Psychiatry at the University of Michigan at their Addiction Center. She studies ways to both prevent and treat substance use disorders spanning developmental periods all the way from adolescence to emerging adulthood to adulthood. She will be joining us virtually, and I will try to make that happen. We'll wait 1 second for her to pop up, and she will be discussing cannabis interventions to reduce consumption and risk among young adults. Please join me in welcoming her.
Okay, thank you, everyone. Really appreciate the invitation. I wish I could have been in Seattle with you all. I love Seattle, and I just appreciate being able to Zoom in from my office in Michigan. So I'm going to hope that everyone can see everything on your end as I am going to be seeing my screen now. So thank you for the introduction, and I will be talking about in rapid fire, hopefully some interventions so I don't go over time, but I do have a few things to squeeze in today. Briefly, I do receive funding from NIAAA, NIDA, and PCORI, and want to acknowledge that I don't have any other financial disclosures that would affect this talk in any way. And I want to start by acknowledging that the work I'm presenting today is a very much the effort of many, many people, and a lot of collaborators make it happen, as well as staff members, and also that the work that we're doing is supported by the generous donations and support of the Kathy and Toby Brosnowski family. So I was asked today to speak about some of my emergency department work with young adults, which I will do, and give you a snapshot, varying sort of breadth and depth into 3 different studies, all in the emergency department. And then talk about some of our potential conclusions and future work, and look forward to discussion. I'm sure at this point into your day, you've had some context on why we, care about cannabis use, why we care about it in young adults. So I won't do a lot of, that background. Just to give you some context for where I'm coming from, I'm in Michigan, and the studies I'm presenting today took place in Michigan. Our cannabis rates are especially among young adults, something of concern. We legalized cannabis for medical use in 2008, and recreationally in 2018. We became the first state in the Midwest and the 10th state in the nation to legalize for recreational use. And if you see here, the yellow line is Michigan. The other 2 lines are the United States and Midwest. And so I will say we are literally higher here in Michigan over time in terms of cannabis consumption. And we're also higher in terms of cannabis initiation rates. And just to show you, again, most recent NASDA data on cannabis initiation in young adults, and teens. Young adults are that line that was shooting up around the years leading up to recreational legalization. They're the line on top. So we have a high initiation rate in young adults here in particular. So it's something that, is concerning given some of the potential downsides for some people. The work I'm talking about today is located mostly in the sort of prevention selective area of the continuum of care model. But I'm a clinical psychologist, and I got my start in substance use disorder treatment. And so that I will say, I think the whole spectrum of care is really important. But what I've learned from working in treatment is I'd like it for people to not need to come into that door in the first place. And so I tend to do work that focuses on interventions at this more selective level and outside of formal treatment spaces. In particular, I've done a lot of work out of the emergency department. And, as a clinical psychologist, this is not the sort of setting I ever trained in. And so I was lucky to have collaborators that introduced me to this as an important setting. And we conduct research out of the ED because it allows us to reach populations that may not otherwise be reached particularly for prevention. So for young adults, not everyone goes to college where there can be great intervention points that are accessible there. And in fact, young adulthood also lasts longer than the traditional college ages. So, this is great to have college interventions, but we also want to think about where else we can do this work. And we know that in young adulthood that there tends to be a little bit of a drop off in primary care engagement from the transition from pediatric medicine. So sometimes people are more likely during this age to use emergency departments as their usual source of care. This data is probably now a few years old, but generally speaking, there's millions of ED visits annually, and about 20 million of those are in young adults. So we also know that people who present in the emergency department for care tend to be more likely to engage in risky behaviors like substance use or misuse. So it just makes sense that this is one of multiple venues where providers could potentially be screening or initiating preventive interventions. But I will say the techniques we use with emergency department patients could really be used in other settings. And the other piece of this is that some of the work in emergency departments and behavioral interventions, BIs or brief interventions, has been really successful in other substances and with different combined risk behaviors like alcohol and violence. And that's been a lot of people doing that work, but especially a large group of folks that I collaborate with here in Michigan. So we've done it, they've done it successfully. And so it's a sort of launching point to do more in this setting. And I'm so grateful that Dr. Walker just gave a little bit of MI background, because this is what we use in all of our work. It's particularly suited to engaging people who are not necessarily thinking about making changes to substance use. So your emergency department patient who could be attending for any reason going to the ED. And also we know it's efficacious as a treatment in its own right. In particular, we tend to focus on the why-how model of MI, which is consistent with the 4 processes of MI and the principles described earlier. And in this approach, exploring why change and how to change are really both essential to elicit and sustain behavior change, and are accomplished through the use of MI skills and guided by MI spirit, with cognitive and behavioral skills integrated as well. So again, I got my start in substance use disorder treatment. Everything I did was face-to-face delivery. But as we have seen technology access, really change over these past several years in the United States, in some of our work, we're using more innovative, modern approaches that can help increase reach of and access to interventions. And in fact, in the cannabis landscape that is rapidly evolving, it is recommended that efficacious interventions, so things that we know might be useful in the brief level, be extended or lengthened to address this problem. And that we can use technologies in healthcare settings to facilitate intervention delivery beyond clinic walls, improving health equity through extended access. So the first study I'll tell you about is a study we called MyReach, and it had an acronym, and it stood for a bunch of things that we thought gave it a clever acronym that patients would remember. And this study was conducted as part of my K-23 funded by NIDA, and we were focused on, I will say, this was an intervention that was initially developed because it was NIDA funded at the time to focus on drug use. But we knew from all of our preliminary data that the vast majority of drug use in this setting was cannabis. So it's we say drug, but it's really 97% is focused on cannabis use. So there may be some applicability across substances here, of course. In this study, interventions were initiated and delivered to participants who were in the emergency department or who'd recently had an ED visit at the Hurley Medical Center in Flint, Michigan. To give you some context, this emergency department is a public level 1 trauma center, and Flint is an urban city that's considerably under-resourced and impoverished. I give some stats here just to help paint the picture. This work was also occurring at the time that when, I would say we're still dealing with it, but we were dealing with a significant water crisis in the community where essentially community members did not have safe drinking water. And so there's also a lot of mistrust of systems going on in this community for really valid reasons. Importantly, in this impoverished community is there's limited prevention resources for young adults with regard to substance use. So our MyReach intervention included a therapist, counselor, coaches. We kind of, use these terms interchangeably, but the therapist is delivering an MI-based counseling session, a brief intervention, and that is joined with 4 weeks of booster messaging consistent with MI that was sent via a mobile app. So our intervention, our BI, emphasized a discussion of reasons for use that was rooted in motivational theories of substance use. And in this intervention, we guided participants, in addition to some components you'll see in a moment, we guided them in identifying their top motives for use and used this to tailor booster messages received through a mobile app. We focused on motives because formative work in the study population that we conducted using a daily process study found that same-day motives for cannabis use predicted increasing quantities of consumption. And as in prior successful work by our team, we used a computer guide that functioned as a clinical decision support tool for the interventionist. To give you a sense of what's covered in this 30 to 40 minute brief intervention, you can see the topics here along with the MI consistent components within each section. We really spend time at the beginning building rapport, exploring participants' strengths and goals, what's important to them. This helps us develop discrepancy, but also helps us, build up that rapport and affirm efforts and affirmed things that build self-efficacy. This intervention was based on prior work, but also refined through focused testing with 8 young adults in the community. So our computer intervention guide really serves to walk the interventionist through steps of the intervention. This is especially important for fidelity in the sometimes chaotic emergency department environment where interruptions happen. So you're delivering a behavioral intervention session, your patient needs to go get blood work, they get pulled from you, you need to come back to where you were in the intervention and pick it up. These are example screens that show prompts and example scripts. This is viewed by the interventionist and reminds them what to do next, and so that helps fidelity. The scripts are included for training purposes. They are not read verbatim by interventionists. That would probably lead to really unengaging interventions, but they're there to help and guide training. On the right, you can see a screen that a therapist can use and also can share, when we're face-to-face and doing these interventions with a tablet in front of us, we can share this and use this as a conversation starter if needed. And these screens also capture within session paradata, so we're recording what's happening in the intervention. And some of our prior work, and especially in a paper led by former postdoc Becky Waller, now at Penn, we found that the topics sort of captured in these elements of the brief intervention and recorded through these screen prompts predicted important MI constructs like behavioral intentions to seek help, importance of and self-efficacy to change, as well as cannabis use outcomes in adults. Just another example showing these screens and how we tailored our intervention. The drug use motives identified by participants were used to tailor potential tools that were discussed throughout the intervention, which were also then populated later and to tailor some of their messaging. After participants completed the 30 to 40 minute session in the emergency department, we signed them up for an app. We used an off-the-shelf customizable app at the time called Life Data. And we sent tailored MI booster messages once a day for 28 days. This is a feasibility acceptability pilot, so they were asked to rate these messages to inform acceptability, and they received $1 per day for each rating and a thank you message. To develop the messages, we used Amazon's MTurk to target 18 to 25-year-olds to write ideas based on theoretically informed prompts, and then we shaped those to make sure they were still MI consistent. So we were using the words and some of the ideas of young adults, but then keeping them theoretically relevant. We then also had 8 young adults from the community provide feedback on proposed messages and thank you messages as well. And then also got additional feedback from students and others in the local community for piloting these messages. Messages rotated over the 28 days to include reflections, affirmations, evocative questions that also affirmed and elicited goals and strengths, and highlighted benefits of change and described tools that were directly linked to the most salient motive they had chose in the brief intervention. Once a week, we also, through the app, did another question where people were asked, we elicited their goals for the week or things that were important coming up for them. So here's a typical day of receiving the booster messages. First, the participant gets a notification in the app that they've got a message waiting for them, and they open the app and they, click the notification to see their first message. This one is focused on tools for coping with negative affect, which is by far the most identified motive for cannabis use in this sample. And all of our messages were laid out over engaging stock photos, mimicking what you might see in a social media feed, which is really organic to young adults, use of messaging and media apps, and was very positively received in focus testing. After receiving this message, participants were asked to rate it to determine, we wanted to know if people hate certain messages, we don't want to use those in a future intervention. So we asked for ratings. And then again, that once a week question eliciting values or goals or things that are important. Based on our focus testing, we also found that young adults preferred an entertaining novel reward. So we incorporated memes as a thank you for each day's rating. Just a few other examples. Here's an example of a message that was focused on tapping into social motives. So you can see some of our messages are more framed as questions or sort of food for thought. And another example of a thank you message. The app also included a startup session to orient participants in a local and national resources section that was accessible 24/7, which we tailored again to the local area. So in terms of the pilot trial of this intervention, we enrolled 63 people and they were randomized to the pilot intervention or enhanced usual care, which included review of community resources. We did have a few folks who were intent to treat or didn't download our app. They may have done our brief intervention, but they didn't do the app pieces. And this really reflects a common challenge in the field. And this is even pre-COVID. I'll talk about COVID-related emergency department work later too, if you want. But getting participants to stay in the emergency department to do some of these research tasks or to stay beyond their presenting concern is more challenging as wait times have decreased. It used to be we had a captive audience, but as EDs get quicker at times, then people want to leave, and I can't blame them. But it does make some of our research procedures that can be more cumbersome harder to complete in that visit. Just a snapshot of our participants' demographics as well, although again, I will say drug use was the inclusion criteria. You can see the heavy consumption of cannabis, 97% used cannabis, as compared to 12% other drugs and 62% alcohol. And of course, there's some overlap there, sometimes people using more than one substance. In terms of acceptability of our session, so again, we're a pilot, we're underpowered to look at behavioral outcomes, and I'm focusing on what did we learn from this about the types of interventions young adults would like or can find value in. And we saw that generally about 80% of participants completed a post-test right after the intervention, 80% liking talking with a counselor, and many of them finding it helpful to discuss substance use. Now, I'll say this reflects the pre-contemplative nature of the sample. These are not people seeking treatment or anything necessarily related to their cannabis use. They're just in the emergency department for any reason. And fewer of them find it, helpful to discuss changing substance use. And we're looking at this as, we're planting some seeds in some people who may be pre-contemplative. In terms of our messages rated by participants during that month-long booster messaging period, 78% of possible ratings were completed. So we had high sort of engagement of viewing and rating the messages daily. And you can see that on average, about 3/4 of participants rated the messages as a 4 or 5 on the 5-point scale. You will see also there's a little bubble there about messages about sexual risk reduction. We did also address that as a secondary target in this trial. I just thought for the sake of focusing on cannabis today, we'll skip over that. You can read about it or ask me about it in the paper. Booster messaging, pretty acceptable. People liked getting the daily messages. They thought it was helpful to focus on what was important. We asked them as well, again, some finding the substance use messages less helpful. At the same time, we asked, did we give you too many messages? Did we give you not enough? Did we give you just the right amount? And most people wanted more. And I think that reflects this population having no access really to mental health or anything sort of positive behavioral supports in this setting, and just the general positivity around some of the focus that we had in our intervention, which I also think is reflected here in some of the things that participants wrote when they were asked each week something important to them or something they looked forward to or plan to do to move toward their goals. I love looking at these messages people wrote to us because it shows young adults were taking this seriously. They didn't troll us. They didn't write anything snarky. They focused on unique and personally important goals and values that highlighted their strengths and resiliencies. So in this pilot study, we found that our BI focused on reducing drug use and related consequences was well received by young adults, supporting the use of MI in our tablet-based or computerized guide. We found that for those who used the app, they enjoyed receiving tailored messages and generally found them fairly helpful. And young adults also engaged with the app by responding about their weekly goals. And to me, this mimics the idea of verbalized intention, an important construct in motivational interviewing. This is a way of articulating change talk, which we know is predictive of behavioral outcomes in MI research. And it suggests there could be promise to more interactive approaches using two-way messaging that could allow participants to continue verbalizing intentions and goals, and for therapists to provide reinforcements and potentially extend the conversation around cannabis use. And that really informed our next pilot, R34 from NIDA, we called Snap Coach, because we ended up using, for two-way messaging, we ended up using social media, and we used Snapchat. And we revised our brief intervention session. I'll show you that in a moment, and used the brief intervention session plus interactive social media messaging over Snapchat. And we did a lot of sort of focus testing, field testing, to sort of iterate to get these approaches, acceptable and beneficial. Why social media? It's probably not surprising in a world where I can come to you from, my home office / guest room in Michigan, that we can use technologies to reach. And social media is something that young people use all the time. Of course, many of us non-young people also use it frequently. It can extend beyond some of the digital divide barriers of the past to reach people. We're carrying around this in our pockets all the time. And in fact, most young adults under 30 say they're online almost constantly. And we wanted to use social media because, and we really struggle with this, I do other work with apps and different technology approaches. And social media is something that's already maintained for us. So it's sort of thinking about using tools that we don't have to consistently pay for to update, and also things that are used by people daily in their life. So it would be sort of normal to get messages in this platform. For this study, we again had 18 to 25-year-olds. They had weekly cannabis use, and they received a brief intervention extended by private Snapchat messaging, or they were randomized to an attention placebo control. Snapchat was highly utilized in our study population, but the reason to use a specific social media platform for any type of intervention goes beyond popularity, because those things change. And Megan Moreno has a really great paper that talks about affordances in social media, and that you want to pick a social media for interventions that has the features that you need, and the features that are most relevant and useful for the population. So we're doing a substance use intervention. We're working with young adults, and they wanted back and forth messaging. Snapchat seemed the best for that, because also they had the choice for the messages to not be saved if they were concerned about privacy or others using their phones or what have you. We also tested, we've been doing our interventions in the emergency department for years and years. In this study, prior to COVID, I think that's important to note, we were sort of thinking about the idea of a behavioral health hub where you have therapists or interventionists who can, be anywhere in a health system, and, through a tablet or through a Zoom type platform, be ported into someone who's in the emergency department or someone who's in another setting. Then COVID happened, and we were like, okay, now we really have to do all of our interventions remotely. And we went from the idea of having staff in offices to patients in the ED to at times not doing that at all because of COVID restrictions in emergency departments. but to having people do their sessions after their ED visit, and both staff and patients were at home doing these things in private locations. So, COVID really sort of shook up the virtual world, and we used that to sort of extend what we were already kind of thinking. Our brief intervention looks very similar to what you just saw, with the exception that here in our formative work, we also learned that young adults wanted to know more about navigating challenging scenarios. So times where maybe they needed to think about ways to cope with stress or negative mood and without using cannabis, or how to navigate social situations, or potential risks around mixing or driving. So we actually added some components of working through hypothetical risky scenarios. What would you do if, and working through that with the therapist. We use a similar computer guide. This time we've moved to having help screens that then can be popped up if the therapist sort of needs to focus on this during training or practice, but then mostly, just having the elements on the screen that might be most essential to guiding the intervention along. So after participants completed our brief intervention, they're linked to a study snapshot account where they receive messages and stories about 9 times a week over the next 4 weeks from a team of coaches. Messages included health coach videos. This is like a GIF I made of one of our health coach videos. Other greetings that reinforce elements of the counseling session and address key themes shown here, like motivating toward goals, affirming strengths, identifying alternative ways to address coping, social and boredom motives, and harm reduction. Sample messages shown here, and I'll show you some on the next slide. They don't always mention cannabis, but they address upstream factors that can influence use. And here you can see, again, some sample messages on how we use imagery and different video links and other greetings to start conversations. Our control group, attention, control, placebo was, not placebo, but attention control was, we're just sending them, normal social media content that doesn't have anything to do with mental health or stress, sort of just general, sort of what you'd see anyway in day-to-day, which had much less engagement. I'm getting short on time, so I'm going to skip over some of the details that are really in the papers that I've referenced, and just say, here in our brief intervention, we saw higher acceptability ratings, and I think that really speaks to taking things we learned from our first study and integrating those elements into our new study here that I'm showing you. We have much higher acceptability, and people, 83% found it helpful to discuss cannabis use. In terms of feasibility and acceptability of our snapshot messaging, they liked snapping with coaches. They felt that MI spirit. Coaches were caring, supportive, and warm and respectful and understanding. They, again, reflecting pre-contemplative nature, less helpful to snap about cannabis use. But if we're addressing motives for cannabis use, that doesn't have to be the main part of the conversation. And in fact, when we asked people to rate the different types of messages they received and, how much they found these relevant or liked them or not, the key messages are at the bottom, the way this figure is organized, but people liked messages focusing on finding healthy activities, focusing on their strengths, and finding ways to relax, among others. And nothing was rated horribly, but I take that away as the things that people needed to hear about were things that would help them in absence of cannabis use, right? So we can't just tell people use less, don't use. We need to help them think about other ways to address why they're using, or other ways to spend their time. In line with hypothesized mechanisms of MI-based interventions, we did see throughout our intervention period important changes, increases in intentions to change cannabis, importance of changing cannabis, and self-efficacy to change cannabis. And what I will point to you here is that the blue line is our intervention group, and that was going up during the 1-month intervention and then declined. And I think, maybe we shouldn't take these interventions away from people, and we should continue to kind of give them supports in small bits throughout their daily lives. In my last 2 minutes, I will briefly tell you, and I'll say I'm open to questions and talking more about this in the future. You're going to wonder why it says opioid on the screen. We are doing these interventions. We have a brief intervention with patient portal-like messaging. So messaging still in this two-way way that I talked about in the last study. We're doing it through something that's more like a patient portal because, health systems have those now and they use them a lot. And we are doing this in a study focused on prevention of opioid misuse and opioid use disorder. In a scoping review we conducted, of course, we wanted to address risk factors identified in the literature for opioid misuse and opioid use disorder. Key risk factors that were apparent in our review were binge drinking, other drug use, cannabis, and mental health factors. And so I want to say we're extending this line of work, and now we're applying this messaging through a portal-like system. We don't use our health system's patient portal because we want to keep research separate from the clinical delivery for now for all kinds of reasons I could get into. But we message through the portal similarly to address these components that are important and highly tailored to what the participant needs, and address, their substance use, mental health, and different components of that through ongoing two-way messaging that's MI-based. It was highly acceptable in pilot work, and our participants received these sessions that are similar in terms of brief intervention, talking through different scenarios to reduce risk for different substance use and to enhance mental health coping. And in our patient portals, we again continue this messaging, and we ask people what do they prefer, to talk about. It was very personalized to what was most important to the intervention, the person receiving the intervention. But, an example quote up here on the left is it, found it useful to talk about cannabis use. And so for those who had cannabis use, which was 68% of our 1,155 participants, we found in preliminary data, and I would say this is highly preliminary, sneak peek, hot off the presses, that we're seeing an impact of this potentially strategy on reducing cannabis frequency and cannabis consequences relative to a control group at our 3-month follow-up. And we're going to be looking at these data as they roll in. And so I feel like I just threw a lot of different things at y'all. I'm hopeful to have a chance to answer any questions that happen. What I'll say in terms of what I view as the way forward with this work is that I'm probably not out of consistency with what others have said. Cannabis interventions for young adults are needed. They're needed now. We've shown that the emergency department is a venue to initiate acceptable and feasible interventions. And we also think that we can have shown that we can extend interventions through engaging means, either social media or patient portals, to boost impact. And with that, I want to thank you for letting me go a minute over, and look forward to any discussion that we get to have.
Alrighty, thank you very much. With that, let's invite the panelists up to sit up here and take our questions. Give you all a second to get positioned. Alrighty, fantastic. All right, so I will direct the first questions to our first two presenters. So for Dr. Kilmer and Walukevich-Dienst, can you please speak to what the hooks were that were described for students that were between 18 and 20 and for groups that were older than that? How did they compare between those two groups? Did you see any differences?
That's a great question. We've really tended to not necessarily generalize hooks across groups of people, because for real, it's all about the person in front of you. For whatever hook is most salient, relevant, and compelling to that person, that's what we do. So I do think, I would stick with that. I don't think that we tend to see differences in that level based on demographics. It's more about, for that one person, what hook is most relevant to them. That would be my 2 cents. I don't know if you'd say something different.
No, I would agree, and I think somebody's like, I like using cannabis, but I don't like how it impacts my sleep. And so you would give information on sleep and, brainstorm ways so that it doesn't impact sleep and things like that. Or I like using cannabis, but I've noticed I've started using in the morning and I don't really like showing up high to work. And so figuring out, kind of what that hook is individually, I think is really important. And we can do that with a lot of the personalization that has been talked about in these types of interventions.
Fantastic, thank you. A little bit further to that, do you see these hooks differing between substances when you compare cannabis to other substances?
Do you mind repeating that one time?
Sure. How do these hooks compare across substances when you compare cannabis to, say, opioids or alcohol? Do you see differences there?
I know I can say that they're very different substances. So often students we work with will talk about hangovers from alcohol as being a not so good thing. I got stuff to do tomorrow. I need to not, maybe I choose to not use anything tonight. So I think that what people see as the unwanted outcomes associated with alcohol can actually be different from what they see as the unwanted outcomes associated with cannabis.
I also think that with other substances, the consequences can be more acute than with cannabis, which can be more cumulative over time. Yes. And so with alcohol, feeling hungover or feeling awful, or with opioids, but potentially overdosing, these are really acute, immediate consequences. But with cannabis, it might take longer to emerge or might not show up as immediately. Of course, there's exceptions to that, but I think that's one of the major differences as well.
Fantastic, thank you. I will put this next question to all of our panelists.
We'd like to yield to Denise Walker.
Whoever would like to jump in first. The question is, how might you tailor these harm reduction and intervention materials for legal cannabis users at recreational stores, at retail stores?
I know that we always cite Fisher and colleagues. They published the article on lower risk cannabis use guidelines. And what they make clear is if people do make the choice to use, these are the different things that they suggest that are more grounded in the scientific literature. Certainly, we continue to learn from the people we work with, and they might identify things that for them have helped to reduce unwanted outcomes or harms. But I do think that as a starting point, there's a published literature that talks about harm reduction guidelines, and we can start with that.
Fantastic.
And just going off of that, if people do choose to use, what are some ways to help them use in a way where they're maximizing some of those good things they're looking for and minimizing some of the not so good things?
Mm-hmm.
Thanks. All right, for Dr. Walker, after this 3-month post-training period is completed for CannTalk, what are the next steps?
Well, we're really hoping that we have developed an intervention that can accelerate evidence-informed practice into Washington State, care. And so I think, the idea now is to hopefully at some point try to figure out how the intervention actually does impact the patients that are experiencing it with regard to cannabis use and psychosis symptoms. But short term, we're going to just try to give it away.
Great. Also for CannTalk, do you think that this intervention could be effective in terms of prevention as well? How do you see that working into that part of the continuum?
Yeah, I think Dr. DeForte and Dr. Souza both talked about how, a cannabis-induced psychosis, even that doesn't translate into the development of schizophrenia, having that episode of cannabis-induced psychosis is a huge risk factor for that later development. And so, you guys talked a lot about opportunistic, events that may really lend themselves well to intervention. And I think that is absolutely a time that CannTalk or other evidence-based practices could be used as prevention for future use or more harmful use. Absolutely. I think also, generally, we kind of are knowing that we need to reduce cannabis use in adolescents generally. So we have versions that are evidence-informed, or not evidence-informed, they're evidence-based, of motivational enhancement therapy interventions that can and should be used as prevention for
Thanks.
adolescents generally.
Great. For Dr. Bonar, let me see. Have you seen in your last study you looked at these interventions in relation to also MOUD treatment? Have you seen the treatment and addressment of opioid use disorder and opioid use be prioritized with respect to cannabis use?
So I just want to clarify that we were doing an intervention for opioid misuse and OUD prevention. So these were not people who are on MOUD. We were people who are young adults who are at risk for opioid misuse and OUD. The sort of latter half of the question, could you repeat that and maybe clarify?
Sure. So in this population and in your general studies, have you seen the addressing of cannabis use take priority or be considered differently than cannabis use or opioid use?
So if I'm kind of understanding this correctly, it's the question and more about, are we sort of prioritizing different substances in our work and in some of the populations? I mean, there's definitely in our field and in our studies an importance of talking about opioids from a prevention standpoint and any substance that might be getting in the way for folks. There are people who are, more in the, I would say, older age ranges turning to cannabis as potential substitution for what opioids may have done for them, and that's certainly something that needs to be explored and understood. In our work with young adults, though, given that we know that early use or misuse of substances is associated with increased risk for development of disorders later on, we want to prioritize all substances. We're seeing an increase in cannabis use here, and so we're sort of focused on that. But certainly when we're doing a personalized approach, we address sort of the substances that are of most concern for the person. So I hope that answers the question in some way.
It does. Thank you. All right. Our next question. So again, generally for all of our panelists, how do you see these interventions and the rest of the field fitting in with how to support folks who are in recovery from cannabis use disorder? Don't all speak at once.
We always say it's part of an overall puzzle. Any one thing you do is it's a mix of strategies. I know that the National Institute on Alcohol Abuse and Alcoholism talks about a mix of strategies being necessary, and that includes recovery support as part of it, but it's everything from policies to then enforcement of those policies, education, prevention, intervention, treatment itself, and then recovery support. So I think always thinking a couple steps ahead. If we're working with someone that says, I'm thinking of considering abstinence, what support would there be? We need to be part of that process, and we need to understand what will happen if they go to that next step. So in many ways, the progression of doing a brief intervention, especially if it leads to someone saying, I'm looking at choosing to stop, is knowing that recovery support is in place.
I also think that just having interventions that are specific to cannabis use is a huge help for people who are in recovery, because I think what they're oftentimes met with is that cannabis isn't addictive, it's not a problem, it's healthy, it's medicine. And it's so invalidating to folks who are in recovery and working so hard to change their path and their relationship with cannabis. And it's similarly those kind of messages or the lore around cannabis that really does not acknowledge any risk of harm is particularly, again, very impactful to folks in recovery with psychosis and who are experiencing psychosis in their families, whose peers and family supports and even sometimes providers, because of this information, are told it's not a big deal. So I think just even the fact that we are providing it, talking about it, asking about the harms, and giving information about, other people do have problems related to it, I think is a huge benefit to the recovery community.
I love that you said that. We talk a lot with people in healthcare settings that when you screen for cannabis use disorder, in some ways that's a patient education opportunity. Because when people are like, why are you asking me about this? That in and of itself, the fact that it validates that it is an addictive substance. I appreciate that you said that.
And then lastly, thinking about relapse prevention as well and what high-risk days or periods might occur. So for example, going back to my presentation, 420 might be an event that might be a high risk for relapse, but also some of the work that I've been doing with Christine Lee at University of Washington, thinking about social settings and social support. So often what I hear from my young adults that I work with is, well, I really want to quit or I want to stop, but my entire friend group uses, and I don't know what that would look like. And so is that getting people on board to do like a group friend-based tea break together? Or what does that look like, having that conversation? How does that change your friendships if you're not choosing to use anymore? And so I think being aware of the factors that are really critical and key to young adults specifically that might contribute to relapse is going to be important too.
Thanks for that. To actually follow up on that a little bit, again, a question for all panelists. Feel free to jump in. Among your studies, did you see specific factors that were indicative of either good or perhaps not so good outcomes in these interventions?
Well, I mean, the cannabis literature for the general population suggests that folks who use for coping motives, so those are the most common motives oftentimes people use cannabis for, are the ones that tend to have the highest risk for cannabis use disorder and problems related to that. And we've also found that in treatment, they tend to be the ones that have some of the hardest times quitting. So I think that just generally from the cannabis literature.
And in line with that, having a co-occurring mental health concern, psychosis, depression, anxiety. I think what Jason was saying earlier about, oh, well, if I stop, I notice that my anxiety gets worse. And so having psychoeducation, that's actually a symptom of withdrawal. Some of the work that we did with the qualitative work with the tea break stuff, people would be like, I really want to take a break, but then I notice I can't sleep. I am irritable, I'm more anxious, so I need cannabis to be able to manage these symptoms. But that's just a really important point for education as well, of like that's normal if you use cannabis every day to be experiencing these things, and let's see what that looks like a week later, providing alternative coping skills to handle that as well.
I won't remember the exact numbers, but because it's over 10 years ago, but in our randomized controlled trial, 212 people, we had people say one of my biggest challenges is that I struggle with memory, and the more often I use, the more I have memory problems, and they would miss their follow-up appointments because they'd say, I forgot about it. We had people reschedule 3-4 times. So we actually got to the point where even though it was an in-person intervention, there were people that if they missed enough, we finally mailed them their feedback and did intent to treat analyses. So when you say, are there some people for whom it worked better or less well, one of the challenges is if someone's saying, I didn't even remember to go, that in and of itself is data.
So I'll pitch this to Dr. Bonar first, and then others feel free to answer as well. For your interventions, how did you decide, what factors did you use to decide how often and for how long to follow up?
In terms of the intervention delivery periods of a month, the idea was we'd done a lot of work in brief interventions, being sort of, the one session, screen expert model without the tea, because most of the tea kind of gets left off. But we knew that we needed to extend the effects, but we also knew that people have priorities in their lives that are not necessarily treatment seeking in these settings. And so we chose to follow up over 1 month in these studies to deliver intervention messaging over 1 month, because some of the other work in these extended interventions that use social media, which is sort of another hat I wear. I've got some other social media interventions. You see drop off in engagement from young adults after that first month, you start to see it drop. And so we wanted to target a time when people would be most likely to engage with us. At the same time, as you saw in the middle study that I presented, we start to see some of those MI constructs that are important for change sort of drop off when we take the intervention away. And so that may speak to needing extended interventions, but we started knowing that engagement in mobile interventions tends to drop off, and we wanted to not have, we wanted to make the most of the time that people are most typically engaged in those.
Thanks. All right, one more question. All of these interventions are very much in their early days. As we think about scaling up and doing sort of larger scale interventions, what do you foresee as being perhaps stumbling blocks and problems along the way, and how might we address those as both policymakers and clinicians?
I can say very briefly, I'm presenting to a group of students in 2 hours, and I'm struck by how hungry people are for prevention content, for intervention content, and how so many of the things we don't really have an answer yet. When people say, hey, what are the long-term effects of dabbing? We'll let you know. I mean, right? Because we don't have this, when you look at some of what people are using, it's enough of a new product or a new introduction to the market that, on the one hand, it's great that they're asking those questions, they're thinking critically. So I don't know if that's a stumbling block as much as it is just the reality of when people are asking and they really want to know about long-term, that's a hook. They're saying, I don't want down the road to have any concerns or challenges. And so much of the research on products being used today in some ways still needs to happen.
Implementation of evidence-based interventions are always a problem, even non-evidence-based interventions. But that's why CannTalk really tried to put a lot of emphasis on what the provider response was early on and try to make it user-friendly, so that right from the get-go, we were really thinking about who is going to be using this and how would it fit into their daily life. We got a lot of information from providers about how they creatively use the materials that we used, but I think that was the advantage. All my other studies are, randomized controlled trials, really in an academic setting, not a real world setting, where we would develop the best intervention we thought we could, and we'd get good effects, but it didn't really take into consideration who was going to be providing it, how it was going to be done, and how it was going to be funded. And I think, so that I think is really the beauty and sort of fun of being able to work on a project that's more locally based and not rigidly prescribed around the science, because it can really work with the people who are going to be implementing it and trying to design and adapt something that will work for them right from the get-go.
And just briefly, these are stumbling blocks, but also opportunities. And so, as Jason mentioned, I think young adults and individuals really want this information. They want to make evidence-informed decisions about their use. But when you Google, some of the questions that folks have, like Reddit pages pop up, which is great at giving personal experiences maybe related to these things, but are not necessarily evidence-based and informed. And so how do we make sure that our interventions are showing up and are accessible and available and honestly free? Because there are several programs out there that have this concept, but people have to pay to download the app or continue to use it. And then second of all, I think assuming that us as researchers know best or know how to frame things. I'm not that far out of undergrad. It's getting longer every year, but I am not hip with the lingo at all. And so I think really bringing in, like you did, Dr. Walker, of asking folks, how do you want this framed? What's helpful, what's not assuming that we know best in how to share the information, I think are two important things moving forward.
Great. Dr. Bonar, do you have something to add?
Yeah, there's probably a time delay, and so we started speaking at the same time. I would just say the other thing that's been a jumping off point or been sort of alluded to is funding, is reimbursement. So I loved hearing about CannTalk. I love that a provider can do that within a session of, within a visit of some type, and that's billable. We need all kinds of interventions right across the spectrum. And some of the awesome things that researchers are thinking about, there's no funding to sustain or bill or provide that. I want it to be free. Someone's got to pay for that on the other end. And so just to the point that, funders and healthcare organizations and different organizations are listening. I mean, that's something we need, is the interventions that fall at different spectrums of need are not necessarily the ones that we can get as providers reimbursed for.